All right, here we go.
The broadcast is now starting. All attendees are in listen-only mode.
Thank you, everyone, for joining us for another Learning Lunch hosted by FormatApproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education with Formed Training, and I'll be your moderator today. Today's Learning Lunch will cover EHR, when to upgrade from old solutions to new. We're joined today by Chris Coleman of C3 Partners. Chris has been assisting clients with solutions to their operational problems for over 25 years, and he is an expert in EHRs in general and meaningful use in particular. We are honored to share his expertise with you today. Please note that you can ask questions of our presenter at any time during today's session by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, please note that all registered attendees of today's session will receive an email with links to both the recorded and PDF versions of the event. So people often ask us during the session if they can get the slides, and don't worry about that. We'll send them to you following the session. All right, Chris, well, thank you for joining us today.
Well, my pleasure.
All right,
pleasure to be able to chat with you all.
I think it's going to be an informative session, so let's go ahead and begin. So tell us, what are the most frequently cited reasons for upgrading a health system's EHR?
Okay, well, as many of you are aware, there's one strong factor that I'll get to in a while, but let me just go through some general drivers of upgrading health systems EHRs. And the first of which, I think, from a business reason or from a clinical operations reason, makes much sense, and that is process improvement. And that can vary from coding improvements, protocol standard, implementing standard protocols within a clinic setting, so that the EHR is enabling standardization of practice, and that makes much sense from a standpoint of patient safety, of follow-up care, etc. So, process improvement. They might be going after new capabilities within EHRs, and vendors are obviously constantly looking for the next great capability or feature function offering to attract new clinics and hospitals as they expand their offering in the EHR world, as far as new specialty supporting capabilities for specialists, etc. Those new capabilities drive a reason for upgrading. If your health system organization changes, think about all the consolidation that has gone on in the hospital world, and pulling together hospitals that have disparate EHRs can drive upgrading of the consolidated system to a new platform or to one of the current existing platforms and upgrading to the latest version. External factors, and here is where the EHR Incentive Program has been a huge impact on the EHR landscape, regulatory changes, but there have been other changes as well, some that are coming and some that have been recent, as far as e-prescribing, the ICD-10 initiative, all have influence on EHR capabilities and need to support mandated programs. Required upgrades would fall under the blanket of, let's say a vendor has stopping support for an older version, kind of necessitating a health system to upgrade. Could be in that area, or maybe an operating system issue, but typically it would be a software vendor ceasing support of an older version, necessitating an upgrade to either their newer offering or somebody else's if you choose to go a different direction. And then finally, economic considerations. There could be an opportunity to either enhance, let's say, some coding, which would allow for better billings, better recovery, and could necessitate an upgrade. So those are primary reasons to look at moving to a new platform in the EHR world.
All right, so what are the key tipping points then in the decision for a practice to upgrade?
All right, so if you look at what we just covered, but what are really the key drivers? What I have seen and what my partners have seen at C3 Partners from a standpoint of what's caused recent upgrades. And again, I haven't sequenced these necessarily in priority sequence, but the whole issue of the current EHR isn't providing the features that are needed in today's healthcare world, as far as either for specialists, and particularly in this area, the specialists, the radiologists, let's say, needing a more comprehensive solution is one example. The ability to incorporate new features like imaging within the patient visit, to be able to look at a prior EKG online and bring that in, making it much more real time for the physician. So those kind of capability shortcomings drive the decision to upgrade. We mentioned process improvement. The Six Sigma in healthcare, the focus on the ability to have standardization of practice, so you can measure physicians across your practice, making sure that you're getting the patient safety and patient results you want from certain protocols and treatment methods. If your current EHR does not support the ability to have standardization and process improvement through standardized protocols, let's say, that will necessitate a decision to upgrade. And then finally, the regulatory mandated upgrades, which the ARRA, the American Recovery and Reinvestment Act of 2009, really drove, obviously the EHR incentive program, which requires certain capabilities in a EHR. That has had a huge factor in the amount of upgrades.
Well, I know we're going to talk more about the regulatory environment, but before we get to that, tell us a little bit more about what are the barriers that providers and hospitals face in upgrading to a new EHR system.
And again, this is maybe true of any software system, but particularly it seems like EHR upgrades are very challenging. And you'll either see some professionals embracing a platform upgrade, or many will strongly resist it. And the resistance to change is a huge barrier, probably the biggest barrier that an organization faces. And so that's one factor in maybe deferring an upgrade, is that the organization isn't ready. They may assess that the cost of the migration is too great, and versus what the benefits are of moving to a new platform. And again, this is maybe outside the issue of the EHR incentive program, but just the total cost of moving, and it's not just obviously the license cost. I mean, that becomes almost a minor cost sometimes. The cost of the training, the disruption in practice, you might lose actual patient visits because you don't have, you're not up and running smoothly on a new platform. It takes a while to get there. And then if the aversion to risk, not all conversions, not all migrations are successful, believe it or not. And it's a huge business risk to, an organization taking on a major upgrade. So they may, if they're very risk averse, they may just defer it. Just say, we don't want to go through this. We have some other issues we have to deal with. We don't want to have to take on that challenge now.
And obviously these factors are somewhat interrelated, so part of the reason why people are resistant is because they don't want to go through new training and learn a new system, which is also expensive.
Correct. The amount of time spent on training, is typically related to that specific area that the EHR is addressing for those professionals. But in general, if the time is not allocated sufficiently, that's when the high risk of failure occurs, is the professionals aren't ready, they don't know how to use the system in the new environment and with the new business processes that the new system is embracing. So you've got both the double change of new protocols, new practice steps, as well as new technology, which is a double challenge of the learning, and not just going through it one time, but being comfortable with it, being efficient at it. So there's that learning curve and the smoothing out of the process, and then you don't always get it right the first time, so you got to go back and adjust the business process, the clinical procedure at times, because you didn't get it quite right, maybe for all of the specialists. So there is risk, and you've got to deal with that.
So then what are some recommendations you can make for successful approaches to getting through these upgrades?
Well, a strong change management program is very important in an EHR implementation, because an EHR touches so many people in a practice, in a hospital. Virtually every professional is impacted, and they need to understand how they fit into the upgrade program, what their role is, where they're going to be impacted, what's going to change in their world, in other words, and understand not only that point, which is important, but understand, okay, there might be some disruption, and acknowledge it up front, and then also make sure that they do not only understand, but begin to own the process change, the system change, as well as the understand the benefits that they're going to get. So, it's nice to tell them what's changing, but it's, if they can believe that, yeah, okay, I understand what we're going through, that there might be some risk, but I acknowledge that, there are benefits to me as a person, not just the organization, but me as a professional. I'm going to get a better access to information for the patient, more timely information, more complete information. I'll get alerts that I didn't get before that can help me make better decisions for patient outcomes. So understanding how to position the program with your professional staff is critical. And, you have to take time up front to make sure that you have a comprehensive change plan for the organization, for the individuals involved in the change. So that's critical. And get that ownership, shared ownership of the change. Understanding the total economic benefits of the upgrade, so that the management is fully behind the change, and that they see the benefit from an economic perspective to the organization, so that they can make other investments from the economic benefits of the EHR upgrade assuming that there are sufficient economic benefits long term. And then finally, as an umbrella or a foundation, I mentioned change management as a critical piece of the upgrade approach. A comprehensive program management approach is needed, and that includes the change management component, which is really the people side, but making sure you've got one of the biggest challenges is the data migration, the patient information, and how best to make sure it gets moved from old system to new system, that it's protected, obviously, in this day and age as you do that from a privacy security perspective, that you have the proper resources, network resources, the software vendor, making sure that they're aligned, they understand the timetables, what if there are any upgrade fixes or enhancements that need to be implemented prior to going live. All that's well communicated. Everybody is understanding roles, responsibilities. It's monitored. Senior management understands and knows their role. They're not there just to browbeat, but to make sure resources are available when needed. There are going to be bumps. You need a contingency plan. All of that is critical in making sure that the EHR upgrade goes as smoothly as possible, acknowledging that there are going to be bumps in the road. So, you know, we've seen that as you do a better job of program planning and monitoring and communicating and involving all those involved in the EHR upgrade, that the problems you encounter become manageable, that everybody is willing to work the extra hours, and they'll be that. The training, they'll make sure that the training gets conducted when it should, and they'll attend and be as ready as possible when you go live. So those are just some key thoughts on how to make an upgrade go as smoothly as possible.
All right, so what's the 800-pound gorilla in the room? And I have a feeling it might be called CMS or something like that.
Related to CMS, yes, and obviously going back to the ARRA Act of 2009, and that's the high-tech act that introduced the EHR incentive program to us all. And I remember in February of 2009, reading about it, and quite frankly, that's when my organization started thinking about, gosh, that's going to necessitate really a paradigm shift in how organizations look at their technology, how hospitals and how clinics are going to assess where they are from an EHR perspective, because this program is not only it's mandating change, it's requiring that if you don't participate and take advantage of the incentives, you're not going to necessarily avoid the program, because there are payment adjustments coming at you if you don't participate after 2014 if you're not a meaningful user. So guess what? You can't ignore it. And therefore, that gorilla is sitting there just waiting. And so that's why the pretty rapid uptake is starting to take hold. The second bullet point of CMS states that over 100,000 EPs have received incentive payments as of 2012. So again, that's still a minority of EPs by a considerable factor, but they're seeing that since the payment flow is, they paid out over $5 billion in incentive payments, and I believe over 2,600 hospitals have also received payments. So it is a factor, and as we all know, that program requires that the professional or hospital use CMS certified EHRs, and that was, a big component of the program. Is CMS specified the certification process, and they had a temporary, now they have the permanent program of certification, and that certification has to meet their stated standards, which are ever increasing, stage 1 over stage, or stage 2 over stage 1, and then ultimately going to a stage 3. And every 2 or 3 years, that is driving change to your EHR and required upgrades, if you will, to allow for these ever increasing and expanding CMS meaningful use objectives. And we all are familiar with those, and not only the specific meaningful use objectives, but also how you communicate the results of the reporting period. That's changing. Going to an electronic submission instead of going to their website to update meaningful use measures. So all those are driving, all those factors are driving upgrades of organizations that are participating in a meaningful use program. Another factor that, there's a survey that the CDC does, and the most recent one I could find, unfortunately, was 2011, but it showed an increase of 56% of office-based physicians are using at least a basic EHR system. Now that's the basic, it is not necessarily the certified version, because it may lack some capability, but so, and that increased by about 7 points over 2010. So they're seeing an increase in the use of EHRs by physicians. So the driver and the discussion caused by the EHR incentive program, may be causing other physicians, some whom may not even participate in the EHR incentive program, to move to an EHR because of just the general discussion about the benefits and the fact that to be considered relevant in practice, you need an electronic health record system.
Well, I just wanted to add that we were at Format Approved, we were in a similar place in 2009, that it was clear that there was a sea change coming in how technology would be used in both hospitals and practices.
Yeah, it's taken a while, to gain momentum in a big program like this, and the government probably is, I don't know if CMS is a little frustrated in the timing of getting to the 100,000, etc. But that momentum's there now, and it's like a big aircraft carrier or something, trying to turn, and it takes a while to get the ship turned. But once it gains the turn, the momentum is behind it, and I think that you will see these numbers increase significantly over the next year, and quite frankly, the payment adjustments start in 2015, and that's a driver. But, there's no doubt about that.
And those payment adjustments, if I recall, they start off at 1% and then they rise by 1% a year. Am I remembering that right?
That's the stated plan. I don't recall if that was part of the legislation, or if that's up to CMS to implement the payment adjustment structure as it sees fit. I know that it has some option on how long those payment adjustments will be in place, so that it could be almost a permanent payment adjustment if you choose not to be a meaningful user.
And I know we're going to talk more about meaningful use here shortly, but the idea here is that practices and hospitals, they're not incentivized strictly speaking, to buy an EHR. The idea is that they have to use the EHR and meet these standards to meaningfully use the EHR. Correct?
Correct. I mean, it's not good enough just to own the EHR. You have to use it in a meaningful manner and report the results back to CMS to gain the incentive payment. I mean, if that's what you're asking.
Yeah.
They do have to acquire the EHR. That's point one. But point two is it's got to be implemented. It's got to be, and they have to meet the meaningful use objectives during the entire reporting period in order to qualify for the incentive payment.
All right, well, let's move on then. So you've touched on some of this, but why are these incentive programs driving so much EHR activity? Fill that in for us some.
Okay, so again, as I just said, in order to qualify for becoming a meaningful user, there are really three major check boxes. You have to be an eligible provider, either critical access, acute care hospital, or a physician, MD, DO, etc. To be eligible to participate in the program. So you have to be an eligible provider. That's point one. Point two, you have to use certified EHR technology, and that technology has to be certified by CMS, and they have chosen third-party organizations to do the certification per their specification. So you have to get software that's certified, that has a CMS certification ID, and so that's another major checkbox. So be an eligible provider, use certified software, and then finally you have to use it in a meaningful manner. And that means meeting the meaningful use objective measures that have been set by stage. So there's a stage 1 set that's being used for 2011, 12, and 13. And then starting in 2014, there's a stage 2 set of requirements that if you've already been stage 1, then you'd move to stage 2 after 2 years, and those start in 2014. Those set of objectives, they are more stringent. They're additional objectives. That means the software has to be able to support those stage 2 objectives. So anybody attesting in 2014 is going to have to use stage 2014 software in order to become compliant. So again, eligible provider, using certified software, and meeting all the measures in order to get the money, or to avoid payment adjustments starting in 2015. So that's why there's such a significant focus on the EHR incentive program and how it has impacted the EHR marketplace. The software vendors are very focused on making sure their software is certified and as quickly as possible certified. One of the reasons why the stage 2 objectives were deferred a year was because software vendors, number one, were having a difficult time modifying their software in time for healthcare organizations to acquire it and implement it in time for 2013 to be able to be compliant for the entire reporting period. So CMS realized that they were too aggressive in their timetable and deferred the second stage until 2014. So gave some breathing room, if you will. But it does. The stages are forcing EHR upgrades, and so we don't have specific timing on stage 3. You could assume it would be 2016, but there was a deferral for the stage 2, so you're not certain yet until CMS makes a pronouncement on that. As I mentioned, the incentives are followed by payment adjustments in 2015. So again, just because you chose not to participate getting the incentive payments doesn't allow you to ignore the program, so to speak. If in the Medicare world, and Medicaid is different, obviously. There are no penalties in Medicaid if you're participating in only the Medicaid program.
And there's some differences in that it's the Medicaid program. It's administered on a state level rather than a national level. Is that a fair assessment?
Yeah, I mean that's correct. The payments flow, through state funding. Ultimately the government helps to offset that. But also, I don't know of any major differences between meaningful use objectives at the state level and the Medicare set of meaningful use objectives. So they're using similar, set of objectives, and the reporting for Medicare can flow to Medicaid as far as compliance. So, but there is a difference in there's no penalty phase in Medicaid.
I see.
And the payment stream is over a longer period of time, and there are more dollars involved for EPs.
All right. Well, before we move on, I just want to mention to our attendees, to our audience, that if you have questions for our expert, Chris, we will. You can go ahead and type them into the chat area now, and we'll present those to him at the end of the session. So go ahead and hit us with those questions if you have any. Let's move on now. So how can providers ensure that their EHR is certified, and what should they consider as they make this choice?
Okay. The foolproof way is making sure that you go to the CMS website, the Chapel website, that has a listing of all certified software. So if you're looking at vendor A and their version of vendor A software, which is Practice Premier or something, some title, that you are able to go to the CMS website, which is the certified listing of all EHRs, both ambulatory. It's sorted by ambulatory and hospital, and then either modular or complete, and ensure that there is a CMS certification number associated with that given version of the vendor's software. You've got to make sure that what you're acquiring has all the modules that are listed as being certified under that particular vendor's CMS certification. So that's point one. You can get there a couple of ways. You can, and I think we're seeing much more vendor-focused certification. Initially, some homegrown and internally developed EHRs. You can certainly, if you're a healthcare organization, develop your own and get it certified. The cost of certification, at least in stage one, was around, I think, around $35,000 for a complete EHR, 5 to 7 for major modules. So, that's another route. But because of the amount of changes going on in the program, I'm just wondering if that's a viable option going forward. And some large healthcare organizations do have a major investment in their own version of software, and it might be a vendor's version of software they heavily modified. That can be certified as homegrown or custom developed, internally developed, and you can get your own certification number that way. Either way, you've got to have that certification number when you go to a test. That's got to go along with the meaningful use measures that you're submitting, for the reporting period. And so having documentation, and this is one point that we make to our clients, is make sure you have a very detailed vendor document that explains what modules you're using or you acquired in the certified version, because CMS and its auditor when they are auditing this program, and we're involved with that as well. They're looking at whether you have documentation that proves that you acquired the modules needed under the certification ID for that vendor software. So that's a piece of documentation you should have and should keep. If you're audited, you may need to present that.
So why is vendor selection becoming increasingly important?
Okay, so as I mentioned, the EHR incentive program stage 1, stage 2 objectives are becoming more comprehensive, more expanded, and from a technology standpoint, they're asking for more interaction across to CMS and the interoperability with health information networks to be able to exchange information with third parties. That's one of the requirements of the stage 1 connectivity issue. Requires that your EHR platform be developed in a way that is somewhat flexible, that it can be easily modified from an open standpoint, open concept of being able to receive information from external systems, third-party systems, and be able to send information out easily. So, that's one criteria that you need to look at past just how feature or function rich is it. Also, how nimble is the vendor itself in able to make modifications to its software to provide enough lead time once that software has been modified to address stage 2 or stage 3, or an interim like they did for certain requirements in stage 1 for 2013. They made some optional reporting available. Was your vendor able to provide support for those changes to the EHR incentive program? As you start measuring a vendor's ability to do some of the more customer support points, it may become more important in your selection criteria as you look for a vendor that can support you through the entire EHR incentive program time period, which is another, 5 years at least. The platform's ability to work, with other software, as I mentioned, is important not only for the EHR incentive program, but also for your other external clinical systems. The imaging, bringing in images, that's part of the focal point of the EHR incentive program, but also for patient care. So the more open environment you can provide in a EHR, the more flexible your system will be. These are some of the factors that are being looked at in addition to just straight, a feature checklist approach or straight navigation usability. These other considerations are are getting weighed more heavily as you make a selection.
So what are key takeaways that people should take from this?
Okay, so I think the upgrades need to be looked at as far as how am I syncing my upgrade strategy with the EHR incentive program stage objectives release, and looking at, all right, if I've got to get ready for, say, 2016, when do I start planning for that? And making sure that I have enough lead time. I've talked to my vendor. I've got to negotiate. Many times what we've seen is you get in a queue for upgrades from a vendor, and if you're in the back end of that queue, your time, your window has been compressed in order to get the upgrade in and implemented. So the lead time planning is important for stages. The ability, obviously, the ability to meet certification requirements is important. Again, it shouldn't be the only factor in looking at a vendor, but it's almost like a requirement that you say, all right, I will not look at a software vendor if they're not certified currently and have a plan to become certified under the next stage, and I want to understand how they're going about that certification process. The ability to adapt efficiently to the changing technologies. The fact that there are certain major EHR vendors that are fairly closed, that don't really open up to other third-party systems easily. That's a factor in this day and age, particularly as, the open system concept, the software as a service, cloud technology, being able to take advantage of those economics and flexibilities. You need to assess the importance of those to your organization, but they have become much more important to the healthcare industry as well, even with the personal health information privacy issue that needs to be considered. And then finally, the looking at making sure you're still delivering operational value, and you haven't only focused on making sure the EHR incentive payment's going to be coming your way, but that the system delivers practical value to the clinicians, to the professionals, that they're able to effectively use it in a way in your setting. So you can become myopic in looking at only the EHR incentive program. You got to make sure you balance that somewhat.
All right, well, we have time for questions and answers. We already have questions from our attendees, but if you're out there in our audience, I'd like to encourage you to ask questions. This is a unique opportunity to ask an expert your EHR and meaningful use questions. So let's get to the first question. This is a question about reporting periods, Chris.
All right.
I'll read it to you here. I have heard but cannot confirm that because MU2 requirements and implementation are so slow, that instead of requiring an entire year of attesting, all MU2 participants only need 3 months. For those just starting with Medicare this year, they will also need only 3 months of data to attest.
Okay, so here's what changed under the 2014 final rule. As we hopefully know, the first year of meaningful use reporting is a 90-day reporting period, and after that you're into a full year reporting for Medicare. And now what they did, though, because of the compressed time that vendors have to get their stage 2 software ready and then have the healthcare organizations implement, for 2014 and 2014 only, there is a 90-day reporting period for everyone, regardless of where you are in the meaningful use life cycle, if you will. So for the calendar year, if you're a physician, or fiscal year if you're a hospital, for 2014 you are looking at a 90-day reporting period. And let's see, if I remember correctly, I believe that has to be quarter bounded. In other words, reporting on a quarterly basis, the 90 days. So when the person who asked the question said MU2, which I'm assuming is the second reporting period for meaningful use, if you're in 2013 and you're year 2, you have to report a full year. In 2014, you can report for 90 days, everyone. So
that's whether that's whether you're at stage 1 or stage 2.
That is correct. Any stage 1 or stage 2, if you're reporting year 1 or year 2, or some could be reporting year 3, you're still only reporting 90 days because of this upgrade issue that we talked about earlier. You've got the software vendors having to, quote, I don't want to say scramble, but that's what they're doing to meet the stage 2 meaningful use objectives support in their software which compress the amount of time that healthcare organizations have to implement that software, which is, and it was a resounding, we're not going to get it out in time for many organizations to be able to use it for a full 12-month reporting period that some organizations would need because they're in year 2 of meaningful use. So they decided to cut it back to 90 days so they would have enough time to do a reporting period that was manageable for healthcare organizations.
So is part of the issue here that you might have practices that by the time the EHR vendor has upgraded their system and they've trained on it, they may not be ready to report until Q3 of 2014. Is that the idea?
Correct. That's okay. Exactly correct. Yep. And it's not really, quote, the fault of the healthcare organization. Why should they be penalized? They didn't get the software in time. So CMS made a decision to reduce the reporting period for 2014 across the board. Okay.
Well, I don't know if this is really a question you can answer, but I'm going to ask it and see what your thoughts are.
Right.
How can you be sure that... I'm sorry, what were you going to say?
No, go ahead.
Oh, okay. The question is, how can you be sure that EHRs are going to continue to certify for coming stages of meaningful use? I think the idea is, what if they're certified for stage 1 and you buy the thing and then, they're not, well, I guess maybe you could find out about stage 2 now. Go ahead and address that question.
Well, that's one of the, looking at as you make a selection of a vendor, focus on the vendor and what its track record has been on delivery of new releases. When they published when they were going to bring out a new release, and did they hit that milestone? There's no, first of all, there is no guarantee that they will be certified for the next stage if they're certified for current stage. But if it's a major player, obviously they are going to have to do whatever it takes to get certified because it's too big a business risk for the EHR vendor not to be certified. If you're dealing with a niche player, maybe there's more risk. I'm not telling you to go to a major player, but you need assurance. You can't get an ironclad guarantee contractually. I don't think, that they will meet the certification requirements for the next stage and you'll have a certified product available to you when you need it. But you need to meet with them to understand what are their resources dedicated to addressing the meaningful use program, what is their program management approach, how many resources do they have dedicated to the coding that's required, and the certification process they have to go through. There are some investigative steps you can go through to make sure that your vendor is internally dedicated to make sure that you're going to have as much lead time as possible with that new release.
So you should ask for assurances from the EHR vendor in addition to doing that research, even knowing that there's no guarantee. It's a discussion you should definitely have with them.
Absolutely, and you ought to have proof from them of, let me see work plans, let me see the staff, let me maybe interview the program manager for the EHR upgrade you're doing. And I want to talk to them. I want to understand how you're going about meeting. It's a resource issue. It's are they a strong program management firm themselves? Because that's what it's all about at that point, is understanding the requirements, translating them into their EHR package, and releasing it on a timely basis to their subscriber base.
Well, this question dovetails nicely with the program management issue. The question is, how far in advance should a practice plan if they are hoping to do an EHR upgrade?
Good general question. Typically, and again, I'm going to caveat it by, how big is a practice? How difficult an environment is it? Multiple specialties, multiple locations, making training maybe more challenging. But generally, you hope to have 6 to 9 months lead time at least in planning and data conversion activities, training, education first, then specific training, data cutover, and then a period of quote, settling in of the system. And that would be minimum for maybe a smaller practice. Larger, integrated delivery systems, you're looking at, 15 months, to do an effective rollout. And depending on if you're implementing some major new capabilities, CPOE is a real challenge. And, if you don't have a solid base of that already, you're going to take an extra 6 to 9 months, probably minimum, to get that effectively running.
All right. Here's a question about Stage 3. What's going to be involved in Stage 3, and when is it going to happen?
Well, as soon as CMS figures that out, we'll all know. I mean, it was published to, 2016. It was going to be every 2 years for a new stage. So theoretically, 2016, if they're allowing 2 years, a period interval. So what's going to be involved? As we know, there were stated objectives of each stage. The third stage was really focusing on outcomes. So not just being able to measure something, but to get an improvement, a measure improvement for a given healthcare outcome. And so that the focus will be, I believe, on trying to achieve better outcomes, right? When my sense is that might get pushed to 2017 just because of the difficulty we have in getting, as we've talked already, the software, the just gaining agreement on what the changes to the meaningful use objectives are going to be internally within the HIT policy committee and the subgroups that provide input to CMS on recommendations of what the meaningful use objectives ought to be. That takes months and months and months of discussion. Then they publish a proposed rule, and then there's public discussion on that for 3 to 6 months, and then they issue a final rule, and I think they allow 60 days before that goes final. So if you stack all that lead time and gain experience on the 2014 meaningful use objectives, I think 2016 is looking a bit tight on when they may come out with the next stage objectives.
Yeah, and I think
But again, don't take that to the bank. That's just one layman's observations.
Well, I think there's certainly a lot of people out there who hope that they do delay it a little bit.
And there's other major initiatives going on in the healthcare industry. ICD-10. What's going to go on with that? That takes up a healthcare organization's resources, and they're already straining on resources and still trying to focus on patient care, patient safety, right? So how do you balance all that? And I don't think they want to rush that next stage out if they feel like those healthcare organizations are already straining, and that's what we're hearing.
All right, well, I think we have time for one more question, and this may be a little bit broad, but the question is, what should we expect/demand from an EHR in terms of HIE capabilities?
I mentioned flexibility, and the ability to communicate externally without having to go into call it the native software code and make modifications. So configurability to communication adopted, accepted communication standards, and I know that CMS has worked on HIE standards as far as trying to get some standardization of health information exchanges in place. I am not an expert in this field. I don't want to put myself out there as one, but I know that at the last several HIMSS meetings, particularly the 2012, health information exchange and the working with EHRs and trying to provide, quote, seamless integration. Well, it's not going to be seamless, but it needs to be configurable, and I think that is the target, would be trying to get to a configurable HIE interface.
All right. All right, well, Chris, we're nearly out of time, but maybe you could take just a moment to tell us a little bit about C3 Partners and the tool that you have around meaningful use.
Sure, I'd love to. C3 Partners, as I said, started focusing on the high-tech law and the requirements of the EHR incentive program starting, gosh, in March of 2009, almost immediately following the law passage. And we have developed a solution, an integrated comprehensive solution for healthcare systems, both ambulatory and hospital, to be able to monitor and comply with the EHR incentive program at a very detailed level, at the MU objective level for either a given physician or for a hospital, working in conjunction with the healthcare provider's EHR. So we take information that's available out of an EHR, populate it into our Meaningful Use Monitor, and provide compliance reporting, monitoring back to the people responsible for the Meaningful Use program at the healthcare organization. So that's one component of our Meaningful Use Monitor. We also do the financial management. We record payments. We provide financial payment projections for a clinic so they understand how much money ought to be coming in from each physician, whether they're in the Medicare or if they're in the Medicaid program. So it helps them to manage that aspect of the EHR incentive program. So if you're a clinic of 200 doctors, that can become somewhat challenging. And we also manage the different stages. So you can appreciate different physicians can be in different stages in the same year, depending on when they started their EHR incentive program participation, and making sure that you're monitoring the correct set of requirements, this MU objectives for that physician. We also do that as well. So we try to be a one-stop shop, if you will, for the EHR incentive program for a healthcare institution.
Well, thank you, Chris. Thanks for the information. I'd like to thank you for joining us for today's Learning Lunch.
It was a pleasure. I hope everyone on board got something out of it. If you do have questions, I encourage you to channel those in. We'll do research and get back to you if we don't have a ready answer, and give it our best shot. So, but I appreciate the opportunity.
Well, to learn more about our industry expert, Chris Coleman, and C3 Partners Meaningful Use Monitor, please visit www.meaningfulusemonitor.com. You can see the URL on the top. I see the one on the bottom has a typo. I'll fix before we send the slides out. I'd also like to thank all of our attendees. Remember that all registered attendees will receive an email with links to both recorded and PDF versions of this session, and we'll get written answers to any questions that were asked out to you as well. ForMed Approved is pleased to announce that the latest addition to our training program provides comprehensive training in meaningful use. We've been hard at work to bring you this new offering, which covers the requirements for both Stage 1 and Stage 2 of meaningful use for eligible professionals and eligible hospitals on the Medicare and Medicaid incentive programs, along with clinical quality measures, HIPAA considerations, and more. Visit formedapproved.com/education/courses_CMUP.html to register for this course. You can learn more about our other training offerings at formedtraining.com. Visit formedapproved.com to learn more about our upcoming learning lunches. The Learning Lunch button will take you to our entire slate of upcoming webinars. Our next Learning Lunch will air tomorrow, June 19th, and will cover the subject of what's new in touchscreen and voice-driven technology for EHR. Keep an eye on your email box and our homepage for other upcoming topics, and thank you again for joining us today.